Welcome to the presentation of part 4 of lecture Crystal Deposition Arthritis. Pseudo-gout or calcium pyrophosphate dihydrate crystal arthropathy is an inflammatory arthropathy with acute and chronic forms caused by deposition of calcium pyrophosphate dihydrate crystal in articular and periarticular tissue. The prevalence of chondrocalcinosis increases with age to involve as many as 20% above 60 years and 50% of the population in the 9th decade. Etiology belongs to 4 groups: sporadic, hereditary, associated with metabolic abnormality, and post-traumatic. Calcium pyrophosphate deposition disease is actually associated with certain disorders illustrated in this table as osteoarthritis, hemochromatosis, Wilson disease, and hyperparathyroidism. Regarding pathogenesis, aging, osteoarthritis, genetic defects, and certain metabolic disorders are thought to induce abnormalities in cartilage that enhance deposition of calcium pyrophosphate crystals. Crystals are shed into the joint and undergo phagocytosis by leukocytes, which release lysosomal enzymes, result in an acute inflammatory response. Synovial cells phagocytose crystals with the release of pro-inflammatory cytokines and stimulate metalloproteinase release, which cause degradation of the cartilage. Clinical presentation of pseudo-gout may be acute or chronic. Acute pseudo-gout, usually in the form of acute monoarthritis in nearly 25% of patients. Elderly women are most commonly affected. Knee joint is the most common joint to be affected. Chronic pseudo-gout presentation may include pseudo-rheumatoid arthritis, atypical osteoarthritis, asymptomatic chondrocalcinosis, or pseudo-neuropathic joint. The precipitating factors of attack of pseudo-gout are illustrated in this table. They include trauma, myocardial infarction, stroke, but the attack may be idiopathic. For diagnosis of pseudo-gout, biochemical studies and synovial fluid studies must be done. Biochemical studies include measurement of serum magnesium and phosphate, also measurement of serum calcium, ferritin, and uric acid, which may be also elevated. Synovial fluid aspiration and examination under polarized microscopy should be done to detect calcium pyrophosphate dihydrate crystals, which are rhomboid shaped with positive pyrofringes. Radiographic finding in calcium pyrophosphate deposition include chondrocalcinosis, which can be demonstrated in 75% of pseudo-gout patients. Fibrocartilage sites that are prone to chondrocalcinosis include knee menisci, symphysis pubis, and triangular cartilage of the wrist. Chondrocalcinosis appear as linear or punctate radiographic densities within the cartilage. Subchondral bone cysts and hook-like osteophytes of metacarpophalangeal joints may be observed. This is an image of pseudo-gout affecting knee joint, seen here in an elderly lady with background chronic pyrophosphate arthropathy. Blood staining of synovial fluid is common in this situation. This is an image showing characteristic elderly female patient with marked knee, wrist, metacarpophalangeal joint pyrophosphate arthropathy. Another image showing bloody old shoulder. This elderly patient has visible swelling of both shoulders. The second image shows calcification affecting metacarpophalangeal joints. This is an X-ray of hand showing typical radiocarpal involvement with cyst formation. Another image of tendo-Achilles calcification. Image of shoulder with periarticular calcific deposit. Another image with large calcific deposit in supraspinatus tendon characteristic of calcific periarthritis. This is X-ray of knee joint showing chondrocalcinosis. Another knee joint X-ray showing hypertrophic osteoarthritic features with prominent patellofemoral involvement typical of pyrophosphate arthropathy. Treatment of calcium pyrophosphate arthropathy include joint aspiration with or without intra-articular injection of steroids, non-steroidal anti-inflammatory drugs, or in chronic pseudogout, it can be managed with non-steroidal anti-inflammatory drugs plus periodic intra-articular steroid injection. For prophylaxis, some evidence favor long-term prophylaxis with oral colchicine for patients with recurrent acute attacks. There may be benefit of hydroxychloroquine in doses similar to those used in rheumatoid arthritis. Secondary calcium pyrophosphate deposition arthropathy is treated in addition by control of underlying disease.